Welcome, everyone. My name is Abby Klostebor, and I'm a Medical Affairs Manager with Nestle Health Science. I'm thrilled to introduce today's speaker and assist with the webinar entitled Nutrition in Cancer Therapy, Opportunities for Prevention and Treatment. I'm very pleased to present today's speaker, Dr. Robert Martindale. Since 2005, Dr. Martindale has been a tenured faculty member at Oregon Health and Science University in Portland, Oregon, where he is currently a professor of surgery and the chief of the Division of GI and General Surgery. He also serves as the medical director for Hospital Nutrition Services. His primary focus throughout his professional career has been on surgical education, gastrointestinal surgery, complex abdominal wall reconstruction, and caring for patients with complex nutritional issues. He has won numerous teaching awards and continues to mentor young physicians and investigators. He is the author of over 300 publications, including peer-reviewed manuscripts, review articles, book chapters, several medical educational videos, as well as being the co-editor of a textbook dealing with surgical and critical care nutrition. His research interests include perioperative methods for optimizing surgical outcomes, preventing perioperative infection, abdominal wall reconstruction, surgical metabolism, management of enterocutaneous and enteroatmospheric fistulae, and nutritional modulation of immunity. Welcome, Dr. Martindale.
Thank you, Abby. Certainly a pleasure to be here today and talking to the group, and I appreciate them all coming. So I will start for note because I've got lots of slides today. So as Abby noted to us, the nutrition and cancer therapy today, we'll talk about the opportunities for prevention and treatment. And you know, cancer therapy has really undergone some major changes recently. We're much more focused on individualized care, and part of that individualized care should be nutrition. So today's objectives are, as on the screen now, identifying the evidence for and against nutrition. There's a little undercurrent that people say, oh, wait a minute, the cancer is going to grow, and we'll talk about that sort of thing. Define the current management of cachexia, and then describe nutritional interventions that can change and improve outcomes. So really, we have to first set our goals with cancer. We set them either in a palliative mode or a curative mode. You know, if it's in palliative mode, then we're obviously not trying to get any shrink to cancer or shrink there. We just want the best quality of life for our patient. And really, we should address this with our patient early on. If we're called by the palliative team to come ask them, can we make things better? We don't really need to worry so much about aggressive nutritional support. We just want to make people comfort. And so in the curative mode, that's when we become aggressive. We should really consider this so in the pre-treatment, during therapy, and post-therapy, because really the treatment in most cases for cancer promotes malnutrition. And that's the problem. And also, obviously, the cancer itself promotes malnutrition. So we've got two hits against us. So we really need to be aggressive. And if we look at the key determinants for quality of life after the diagnosis, really, as you can see here, you know, cancer location, weight loss, and intake. So 50% of the people that answered this survey, these are all people with cancer, all they're the physicians that follow these. Paula Ravasco does very well at this. She shows 50% of the situation is because poor quality of intake. So the ability to eat is a huge issue when it comes to cancer care. If we look at the prevalence of weight loss, you can see on the left side there, all of those head and neck, esophagus, stomach, pancreas, all of those have significant weight loss. And if we think about that, if we look at the bottom there, weight loss can be a better predictor of outcome than the TNM staging system. Now, it's a tumor node MET staging system. So really, the weight loss is a big indicator here. So we really should then say, should we be looking at weight loss or lean body tissue loss, really is our question. You know, there's several screening tools out there. There's the MUST, and there's the NRS, and Nutritional Risk Score 2002, and then the Nutrix score, which we have now. These are scores or screening methods. These are not for telling us what the prediction is, what their outcome is going to be. This is just screening to see who might be at risk. Remember that Nutrix score is only validated in ICU therapy. When we talk about body composition, we really should think about this as that's how we're going to tolerate therapy, how well they're going to tolerate, how much we calculate doses. There's a huge shift now in cancer care, we should not just be talking about BMI and not doing chemotherapy based on body weight, but actually based on lean body tissue. So we're starting to see people in some protocols where we adjust the chemotherapy content and regimens based on their lean body tissue. And as you know, this next slide, this slide that we're up now, shows us these are 3 people with esophageal cancer with 3 different BMIs, BMI 17, 28, and 35. If you look at those, you say, oh man, this guy in panel A there, he's going to do very poorly. That's the, CT through the 3rd lumbar vertebrae because he has no reserves. Look at the patient on the right. They got lots of reserves, but look at the muscle. Only the red part there is muscle. The green is fatty replaced muscle. In actuality, that patient has a much worse outcome than the patient on the left. So what they look like in the outside may, in fact, not be really the case. As you can see, the new way to diagnose lean body tissue loss and predict outcome for most cancers is actually looking at lean body tissue to the lumbar vertebrae of L3. I have to say, the dietitians who work with me, I'm very privileged to have some excellent dietitians. They will look at the CT before rounds and say, oh, this guy's got a problem. And they'll bring it up on rounds. Let's look at the CT, and we'll look at the L3 vertebrae and say, oh my gosh, look at this. So, I mean, to think, we have to start looking at multiple ways to do it. And almost every cancer patient's got a CT already. So now we know that the best predictor of outcome, better than any other predictor known to us for pancreatic cancer, colorectal cancer, lymphoma, esophageal cancer, it goes on, is the lean body tissue ratio to fat ratio at the lumbar 3 vertebrae. That software is now free. We can talk about that during question and answer. I paid $4,600 the first time I bought that software, but now it's absolutely free, available on the website too, so you can do this calculation yourself. So now look at this. This, I think, is really the proof of our concept there. This is same stage of disease, esophageal cancer, as you can see there, looking at cumulative survival in months. Obese patients without sarcopenia being those that live fat longer there, you can see. The sarcopenic patients, you can see, live much less than 25% less. This is for the same stage of disease. Very dramatic differences there. And we've all seen this chart. We all know patients, and once they start getting their chemotherapy diagnosis, they get their chemo, then they get surgery, then they get adjuvant care, then they get palliative care. And we know that over 250 clinical trials of just giving nutrition offers no reversal of cancer cachexia. And that statement right there in this slide right here shows us that it's got to be more than just nutrition once they're already cachectic. And I think, we have a big cancer center here. Phil Knight has been very benevolent to OHSU, and we got a huge cancer center. And that's Phil Knight owns Nike, and he's given us $1 billion to study cancer. The problem is most of our chemotherapy doctors will say, well, it doesn't really do much. It doesn't do much because they waited too long. If you wait too long to start, as you can see, we now should define cancer cachexia into pre-cachexia, cachexia, and refractory cachexia. And what happens is I feel bad for these guys because most of the time they get seen by them, they've already got refractory cachexia or they have cachexia. We need to catch them when they first get the diagnosis. And that's when we need to address a nutritional therapy and plan. So getting aggressive early nutritional intervention is the way to treat these cancer patients. Then we won't have 250 prospective trials showing no benefit from nutrition. And those guys become cynical because they read the papers, go, oh, nutrition makes no difference. It doesn't matter. They're going to die. They're going to be sick anyway. So that's not the case. We need to go after appropriate nutrition early. Now, there's new issues. We've learned a lot about the metabolism. This was really the first big article that showed us this. This was in Science magazine, 2011. Obviously, Science, very good. So what they showed basically was the tumor secretes multiple factors. And one of those factors, in fact, not only affects the liver and the brain and the muscle like we knew it did, it also affects the adipose. And so people go, wait a minute, what's the adipose got to do with the patients, except we lose fat? Well, if we look at the next slide, some beautiful work by Ken Sferron's lab just before he, in fact, passed away, shows very nicely that they have a wild-type mouse and just a regular old mouse, and then they have here a mouse with a knockout for this lipase. Okay, so what he did there shows you that in a normal mouse, when they implant this cancer, what happens? You get increased lipolysis. The lipolysis then activates the muscle breakdown. Now, if you look at the knockout mouse, the mouse that doesn't have the receptor for that lipase, if you have that, he cannot break down fat. And in fact, his muscle is preserved. And I don't want to bore you with the details of knockout mouse and all that business. But what this exciting research shows is there's multiple factors. And not only do we think about muscle loss, we've got to think about fat loss. And in fact, fat may be the precipitating factor here. We've learned a tremendous amount about neural circuits and suppressing appetite. If you look at the bottom panel there by this paper published by Dr. Yu in Nature 2017 is very interesting. They show now that there's a receptor not in the hypothalamus. Remember before we always thought the hypothalamus was the center for appetite control, weight control? This is not in the hypothalamus. It's a non-homeostatic body weight regulation. So in other words, when you have stress or chemotherapy or ICU stay or multiple other things, we lose the normal control of our homeostatic mechanisms. And that's what's then becoming clear. Again, I'm not going to bore you with the details of it, but I just want you to know there's some very exciting things going on that we're learning about how the tumor actually infiltrates the tissue, activates multiple things, as you can see by this beautiful review article by Vicky Barakos, and activating how it affects skeletal muscle, the heart, the adrenal glands, the brain. So this is very complex now. This is not just simple weight loss with cancer. This is now through multiple regulators, multiple stress factors, and multiple new factors that cause a crosstalk. And this sort of summarizes that. Under normal situations, as most of us know, we have a pretty regulated homeostatic mechanism. We all vary as adults between 2 and 3 pounds, unless we're gaining or losing lots of weight. But generally speaking, we stay within a couple of pounds over several years. Well, when we have illness, we lose that ability and we go into alternate pathways. And one of the big alternate pathways is because of the Warburg effect. And again, I don't want to make everybody a biochemist. I personally love biochemistry. My PhD works in biochemistry. But basically what happens is we used to call these feudal cycles. Well, in the 1920s, when Dr. Warburg was in the peak of his scientific career, he got a nice picture of Warburg with his favorite dog there on the left side. You know, he was brilliant. He truly was brilliant. He showed that cancers take up more glucose and they don't burn other substrates very well, like up to 20 to 30-fold increase in glucose uptake. And that's kind of stimulated everybody to say, oh, don't give glucose during cancer. We'll talk about that later. But really what he showed was that's the cancer's way to trick the normal metabolism because it can regulate the glucose uptake. And so the tumor basically it rewires the metabolism of the body to promote growth and survival of the cancer. So if the cancer is trying to maintain itself, it will increase the glucose and the conversion to lactate. Well, then the lactate is very interesting. Even in the face of normal mitochondria, obviously, to use the Krebs cycle and the TCA cycle, we get 38 ATPs. To get glucose to lactate only gives us 2 ATPs. It didn't seem to make sense. So before we understood this, we called them feudal cycles. The body just burning up energy for nothing. Well, in reality, that's the tumor taking control of your metabolism and allowing then the tumor environment, the peri-tumor environment becomes acidic, and it changes the way the other cells can work, so making survival for the cancer better. So it's not feudal cycles. These were not feudal, in fact. They were for the health of the tumor. And, what we know that's where this whole concept now we hear about intermittent fasting. Well, what does that do? When we go into ketosis, we see synaptic plasticity. So we see neurologic effects. We see basically, reduced glucose utilization in some tissues, more in others. We see better heart rate. We see insulin sensitivity improve. We see increased insulin sensitivity in the muscle. So again, if we starve, the idea that starving a tumor may work. Well, in reality, it does in some cases. But I think this very nice work illustrated here by some work by Alessandro Laviano, who's an oncologist in Rome, shows very interesting concept. What he shows here is if you look on the left panel, basically if you let ad lib mice and implant a tumor and then give them chemotherapy. Okay, so you get normal cells and cancer cells, you give chemotherapy, and then what do we see there? Is we see the destruction of the normal cells here, and we also see shrinkage of the tumor volume. But interestingly enough, if we do a short-term fasting and then give the chemotherapy, what happens? The normal cells are able to undergo when they see fasting, they undergo a regression of their metabolic machinery, whereas the tumor cells don't have that ability to stop. And so we see an increased objective response in tumor cells and a decreased the effect and toxicity of the normal cells because the body during starvation withdrew some of its metabolic machine. We just say, let's hold off and not divide, but still the cancer cells are rapidly dividing. So we're tricking the cancer cells versus the normal cells. It's a very nice system and works very well. And we know, we've seen lots of data now. This is a nice in cell metabolism, normal cells and tumor cells. And again, I don't want to bore you with all the details, but we see protection in the normal cells with decreased growth in the tumor cells when they use this method of sort of temporarily short-term starvation. Well, I'm going, what you're thinking to yourself, what are you talking about starving? We can't be starving our tumor patients. Well, in fact, this is very short-term starvation, and we do it in a very controlled manner. The concept of ketosis, where if we have a ketotic situation, as you can see in this nice paper in Cancer Biology 2018, some very interesting thoughts. If we look at ketosis, what happens? We decrease inflammation, we decrease some of the enzymes responsible, for chemotherapy, for activation of the tumor. So increased quality of life and mitochondrial health, etc. So now if we look at that, let's look at some of those models of starvation, okay? This is a glioma model, a brain tumor model, okay? And the one is the standard diet versus the ketotic diet, as you can see, and look at survival there. Same thing. But now look at the bottom panel of that left side. I'll use my mouse here. This one here, where now we give standard diet plus radiation, you can see rapid, basically survival to death. But if we give ketotic diet and radiation, look what happens here. We have a lot bigger tumor survival. So it made protected from the chemotherapy injury by doing this ketotic diet with radiation. So again, these are animal models, but I think it's showing us that the ketotic diet may be part of some of our future. Remember, though, this is a brain tumor, not all tumors. So we've only got this data now for the brain tumors. So I think that's where we're heading. Same sort of thing here and some other tumors here, as you can see. This is tumor size here, and you can see fasted there. Fasted is this control group. Fasted is here. This is now cisplatin-based chemotherapy there, and a fasted plus a cisplatin-based chemotherapy. So the best response is those patients who got fasting plus cisplatin-based. And same thing here for doxorubicin. And so different chemotherapies have a different way to work in this fasting model. So I think we need to keep this in mind for future and realize that the tumor cell is very good at inventing new pathways to overcome a normal regulatory response. So we're now fighting back with trying to regulate the host metabolism to actually use what the cancer does against itself. So now if we look at this, we need to really think of cancer now as a multifaceted nutritional approach. We've tried energy intake. Giving just food, as we mentioned, does not work. Just giving more calories, more protein does not work. That's why we've got such a nihilist approach by a lot of chemotherapy, a lot of oncologists. And well-studied early promises increasing activity. Not well-studied yet, but will show some promise. We'll talk about that. But the current major focus is controlling inflammation, as you can see here. So we're going to look at that and say, what about this whole concept of inflammation? Well, we know inflammation comes from trauma, from stress, from being in the ICU. plus also from chemotherapy, inflammation. We talk about inflammation controls all this. We could talk about inflammation with any of these diseases, but today we'll only talk about cancer. I mean, I'm a ICU guy, and I like to talk about it there. But look what we've done in society today. What has happened? Look at all of our infectious diseases are dramatically decreasing. This is from 1950 to 2000. Okay, this is in my lifetime. But look what's happened to the inflammatory diseases from 1950 to 2000. Asthma, rheumatoid arthritis, obesity, multiple sclerosis, Crohn's disease, diabetes, asthma, etc. All a major problem, neurodegenerative diseases. So what's happened here? What have we done? You know, we have now an inflammatory population. Our population is inflamed. And we all know there's a close association between inflammation and cancer. I mean, H. pylori, which causes inflammation in the stomach, is a class 1 carcinogen as defined by the World Health Organization. Now, in the United States, that's not such a big problem, but guess what? In parts of Asia, that's the number 1 cancer, gastric cancer. But look, there's not just gastric cancer. Hepatitis C in liver, human papilloma and cervical cancer, chronic cystitis and bladder cancer, IBD and colorectal cancer, on and on and on. Inflammation causes cancer. And unfortunately, our population now is inflamed. Obesity, we know, is an inflammatory focus. We know that 20 to 40% of cancer deaths worldwide are related to chronic infection or inflammation. Remember, what do they have in common? A neutrophil is very much like a cancer cell. It does all the things a cancer cell can do. Invades tissue, sustained angiogenesis, inflammatory microenvironment, like we talked about the Warburg effect, giving a lactate in the environment, self-sufficiency growth signals, limitless replication potential. So think about that as we talk about this. So let's think about what can we do? The anti-inflammatory thing, we've all seen the list of all the things now, and turmeric and red wine and ginger and all these things, you know, omega-3 fats, probiotics. You know, we're overwhelmed with the number of things people say, oh, we should be taking this, we should be taking that. But where do we have science? Where do we have hardcore basic science to prove it? We should look at those things. I'm not saying discount all these things, but we need to follow where we have science already and then investigate these new things for more science. Omega-3, we have clinical data and biochemical data. We can see on the left side there, you can see decreased cancer cell lines. We know it works there. You know, we know in fish, there's some associations. We know fish consumption and colorectal cancer now. There's 22 studies, prospective cohort studies, with showing a high fish consumption decreases colorectal cancer. So I think we got pretty good data. We also have very good data showing that, in fact, people with a high fish oil intake have an increased therapeutic window. Okay, the therapeutic effect goes up and the toxicity goes down because we widen that therapeutic window when we're on omega-3 supplementation. We know that EPA, DHA in animal models, we can show decreased tumor effects, increased therapeutic effects, enhancing tumor toxicity with the 2 anti-neoplastic drugs. And again, these are all very well described and by very good investigators. So we've got lots of data. But what we haven't talked about is what's really new in the area of chemotherapy. What's fascinating is this whole concept now of inflammation resolution. Because remember, and it's an inflammatory disease, cancer. So if we can resolve that inflammation, or we can resolve a focus of inflammatory disease better, not just inhibit it, but actually if you have it, because we can't, in many cases we already have it, we need to resolve it. Well, in fact, we know that inflammation has 2 phases. We have the initiation phase and we have the resolution phase. So the key is every biological system has on signals and off signals. So what we're learning about now is that we have new off signals, and in fact, omega-3 fats are one of those off signals. If we consume omega-3 fats, we have the substrate available to produce what we now call SPM, specialized pro-resolving mediators. Those are resolvins, protectins, and mauricins. We used to call them those, But now, because we've found many of them, we have to say they're a whole class of drugs which cause resolution of inflammation and tissue repair, which are perfect. You say, well, what's that got to do with cancer? Well, let's talk about that. We know we find our body can produce these. Remember, these are made in your body if you have omega-3 fats circulating, which all you got to do in your diet is eat them. Okay, so you can see here the omega-3s. You can see here that, in fact, when we take omega-3, that's a very nice 8 healthy subjects, took 4 grams a day, and made this whole series down here of these downstream SPM mediators, which help resolve inflammation. Okay, so if we look at SPMs in cancer, they are bioactive lipids. Okay, cancer allows or stimulates persistent inflammation. These actually show a decreased inflammation. We know that cancer has defective inflammation resolution. We know because they shut down the ability to make these SPMs. SPMs affect it, and actually SPMs have been shown to decrease cell proliferation and survival of cancer cells, decrease inflammation, decrease angiogenesis, and now in animal models, we've actually got decreasing metastatic disease from SPMs. This nice paper here, published just a few months ago in the journal of the FASIB journal, a very excellent journal. They showed that, we know that cancer treatment is a double-edged sword. Cancer therapy reduces the tumor burden by killing tumor cells. What happens? The tumor debris stimulates inflammation, right? Dead cells, the body looks at that and says, we got to respond to that with inflammation. Well, in fact, debris-stimulated tumors are inhibited by anti-inflammatory pro-resolving mediators, so essentially enhancing the endogenous clearance of the tumor cells by that. And so with regards to SPMs, we show SPMs play a crucial role in cancer resolution, inflammation resolution, and decreasing angiogenesis in the tumor. So I think we're well on our way now to have a better understanding. You say, well, what are these SPMs? I've never heard of these SPMs. Well, I got excited about SPMs a couple of years ago when I got to spend some time with Charlie Surhan, the guy who discovered these. And he actually has gone on to show that they're factually evolutionarily with us for a long time. The same genes are in these little, flatworms as in the human. And we got lots of models now. Cancer chemotherapy just being one of those. And I've had some personal experience with inflammation, and I took these, and that's N=1, so I won't bore you with the details of that. But anyway, so I think we need to look at EPA and DHA as a new tool we can look at in cancer chemotherapy, prevention, and treatment of inflammation. What about protein? And we know that we lose lean body tissue with any big injury or sepsis or cancer, but we know that protein in the critical care settings, certainly remember, we don't store any protein. Skeletal muscle being our largest pool, unfortunately, in chemotherapy, we rapidly lose that pool in association. I think there's excellent work here by Zudin Puthachary is 63 critical ill patients expected to stay on a ventilator for at least 7 days, and look at the rate at which we lost muscle. He looked at the loss of lean body tissue by 3 separate mechanisms. Looking by ultrasound methodology here, he showed 10% loss, a cross-sectional area of the rectus femoris and the thigh. He looked at cross-sectional area by biopsy, as you can see here, losing 17% of your lean body mass while you're in an ICU. This would relate to the post-op cancer patient. The ratio, which is probably the best meter of loss of protein, looked at ratio of DNA to protein, and 29%. This is in the face of giving 0.7 gram per kilo, which is the average for ICU patients. So 40% of people showed these severe mild, you can see these inflamed tissues after 7 days, these inflammatory cells here and loss of satellite cells. So we have to look, what's the reason here? And in fact, the diaphragm muscle is lost even better. This compared loss of diaphragm during ICU stay versus loss of skeletal muscle. And when you're on a ventilator, you lose your diaphragm muscle even faster. So what does that mean to us? The mechanistic data recently showing us now that, in fact, more protein can increase synthetic machinery. And this is just a few of those using tracer technology which is a very nice method that looks at whole body protein synthetic machinery, not just nitrogen balance where you know what they're losing. This looks at synthesis and breakdown and tells us what's really going on, and lots of good data. Well, what did we used to say in the past? Well, I taught for 25 years that after about 2.5 grams per kilo in the adult, you're probably not doing anything that's just going to fat. I can remember saying those exact words. Well, this work by Olav Ruegers is very exciting because what he showed here was, as you can see in this left panel, as you increase protein intake, you continue to increase, this is whole body protein net balance. Total body protein net balance. So that's going into the muscle. And he showed here by looking, well, what happened to breakdown? Did it go up? Did breakdown also go up? Well, look at this. Phenylalanine oxidation did not change as we increased. He's actually taken this out to 3 now and still continues to show that same graph. So I think very exciting work. So if we look at anabolic resistance, well, we know people with cancer have anabolic resistance. It takes more protein to gear them up, to get them going, to turn on that machinery. And you can see there's lots of reasons for that. And we have many factors to explain that. And we won't go into detail, but just suffice it to say that young people and old people, as a good example here, you can see, look at this as 0.2 gram per kilo of protein turns on protein synthetic machinery. In an old guy like myself, it takes about 0.4 gram per kilo to turn on metabolic machinery and start making protein. So we see this in cancer and stress and trauma and prolonged critical illness. It takes more protein to turn it on. And I think our wave today is moving towards more protein. So again, what's been suggested to protect us from the sarcopenia we see in muscle loss? Increasing the amount, no question, trying to overcome anabolic resistance. You know, there is a little data for leucine and leucine metabolites, HMB. The data is for leucine probably a little better. Whey protein, some people argue, additional glutamine, arginine. Of course, they're not giving much glutamine anymore because of the redox trial. But the big one here is resistance exercise. If you take that combined with increased protein, you're going to see a significant benefit. Remember, anymore, just giving nutrition alone is probably not adequate. We need to give nutrition with exercise. So, does it matter if we have animal source or vegetable source? Probably animal sources are better, although, you know, they can argue that back and forth and ad nauseum. But generally speaking, animal proteins give you a better amino acid ratios, et cetera. So what about specific types of protein? There's a little data now starting to come out about whey protein giving us increased insulin secretion noted when compared to other protein sources. And some people would argue it decreases insulin resistance, as you can see in a series of papers that are now starting to come out. Normally, in some, we learned this from our athletic studies where we talk about protein uptake. We're starting to see it now in other systems. So I think whey protein may come out to be a little beneficial over some of the other sources. But we have to look at total protein uptake, so there's a lot of questions in that area. Well, is there an upper limit of protein? Well, I would have said 2.5 in the past, but I have to say some very good workers, Nick Deutsch and Bob Wolf, the two of the world's experts in protein metabolism and tracer technology, they're showing the anabolic response, remember, is the sum of the fractional synthetic rate of deposition and decreased catabolism may in fact be shut off if we increase our protein, so we can decrease the amount of loss if we can increase our protein. So, you know, we've seen data now as high as 3 grams per kilo. So I wouldn't suggest that yet, but I think over the next 6 months to a year, watch the literature because I think we're going to see it. What about other things? What about probiotics? I mean, and some of you may know me, I love probiotics. I think it's an underserved area. But I mean, look, there's over 200 articles now in 2010 alone talking about the GI protection of probiotics. And what happens when we get chemoradiation? We wipe out the normal healthy mucosa. 5-FU, decreased diarrhea. In 7 of 11 studies, there were people that were getting 5-FU. What about people getting methotrexate? These are mostly animal models, but protected from the loss of lean body mucosa and body weight. This is the cisplatin based here. We don't have a lot of success, but use now, and it's coming. It's coming. Look at this data in cancer. It's called OncoTarget. Very good journal. And they showed, in fact, that we decreased the loss of lean body tissue when the animals were on Lactobacillus reuteri, a common bacteria in some of our probiotics. We now have evidence to support the short-chain fatty acids, which is a substrate the bacteria make. They make short-chain fatty acids under fermentation with the right substrate. And you can see essentially butyrate potentiates the effect of exercise on muscle maintenance. Excellent details of this. That's coming. So I think we have to say there's a lot of exciting things which are fairly simple, fairly inexpensive. With omega-3 fats, with probiotics, it's getting very interesting. Now, I put this slide because I really believe the nutrition cancer prevention has been underwhelming, and people have said, "Oh, it doesn't make a difference." Well, you hear 1 week this, 1 week that, doesn't change. Well, we've lost it in the translation. They've lost the science. Look at this data on whole grains and cancer prevention. And a noon there, British Medical Journal, 2016, decrease all-cause mortality, including cancer. Zong, circulation, 750,000 participants in a prospective cohort study, decreased all-cause mortality, cancer. Reynolds, just published in Lancet about a month ago. Look at this, 180 prospective trials, 58 clinical trials, 15 to 30% decrease cancer, stroke, diabetes, and GI cancers, a decrease in all-cause mortality. This is simple to get our patients to do this. You show them this data and they will start listening. Okay, so I think that's key. What about this idea of obesity? We've got to do better than we're doing with our control of obesity. Look at neoplastic diseases, prostate cancer, breast, ovarian, endometrial. Look at this nice data out of the New England Journal of Medicine. Liver, 4.5-fold increase in liver cancers in people with BMI over 30, and 35. What about, that's in men. What about women? Uterus, kidney, cervix, pancreas, all dramatically increased in obesity. So we've got to do better than that. This is prevention. Then the idea to sugar feed the cancer. You hear that all the time. People, oh, I can't eat sugar. It's going to stimulate cancer. Well, in reality, it does not stimulate growth of the cancer cells. Granted, the Warburg effect has a 20-fold increase in carbohydrate metabolism, but we've not seen data to say it's the cancer, it's the sugar alone. It's probably the insulin resistance associated with it. So I think that we have, what about vitamin D? We all thought that was going to be a big answer. We know it inhibits, sun exposure delays the onset of colon cancer, all sort of retrospective, big database studies where they went back and said, oh yeah, look, people that got more sun did this, people that. But in reality, we've got to be careful here. We got to say benefits beyond bone health have not been recognized yet and confirmed. It's mostly anecdotal old data from retrospective studies, not prospective randomized studies. So we can't really say that vitamin D is going to decrease cancers until we get some better data. What about antioxidants? Well, we're all very excited about that. We know that 40 to 80% of our patients are using supplements. Once they get cancer, they get real interested and they start taking vitamins. A little too late, probably. But the question is, what's the data there? Well, we had some data that's some interesting in prevention. Some of the larger trials, again, showed no benefit. Antioxidants during chemotherapy, we got to be very careful because we may affect the agents or anti-oxidative agents. A lot of chemotherapy agents cause oxidation. So we got to be careful and make sure our people understand, what they're taking and what they're not taking. We had a big trial, the SELECT trial, which we were going to give zinc. And remember, this is a combination of zinc and selenium and vitamin E, selenium, vitamin E and combination. And it didn't cause, of course, the press headlines was antioxidants cause no help in prostate cancer. Well, in fact, it was stopped for futility and not for not because it had no effect. I mean, not that it's caused a problem. So again, be careful what you read. Now, what about risk-benefit ratios? In fact, we could have, remember, excess calories cause hyperglycemia, inflammation. Remember, giving high-fat diets cause inflammation. Refeeding syndrome, we can hurt people. Excessively aggressive enteral feeds, aspiration, compromised gut, access complications. Putting in pegs is not benign. J-tubes, nasoenteric feeding tubes. Giving nutrition during chemotherapy to nullify the effects in some of the oxidizing agents we don't want to give antioxidants. So I think we have to, but the big question really is, well, does nutrition stimulate my cancer to grow? In reality, we have no data in humans that actually, there's one small paper out of Jacksonville, Florida, years ago, where they actually gave a marking of, basically a labeled nutrient, and then they actually 6 days later looked at the tumor growth and showed that there was slight increase in that tumor that they took out of the patients in some increased growth. But in general, there's really very difficult to answer and depends on tumor size, the relative number. We've tried to find it by looking at size, number of patients in S phase, thymidine uptake, tumor protein synthesis, and we just can't show that nutrition alone. The animal models you've heard about, which have been widely extrapolated into human models, what they do is they implant a sarcoma or different tumors in the animals, and when the tumor is 25% of the weight of the human, of the animal, then we start to see increasing growth of the tumor when you give food or give extra therapy. So I've only seen in my life as a surgeon one tumor that was 25% of the mass of the patient. That was a liposarcoma that weighs 53 pounds and a 150-pound lady. But again, those tumors are so few and far between in humans, we can't make that conclusion. The ESPEN guidelines, if we look at the European Society guidelines there's strong recommendations for patients with GI cancers undergoing surgical resection to use the concept of immunonutrition, fish oils and arginine in that case. That gives a strong recommendation. So where do we have recommendations here? You can see these are surgical patients in these papers. Darren Halen was the first group, John Drover, 2011, to do a meta-analysis to show the decreased infections. The Annals of Surgery, 26 papers there, decreased infections. You can see then Emma Oslin, the very next paper, only looking at cancer patients, 21 studies, 2,000 patients, again showing decreased infections. Then the Japanese guys looking at all comers from major upper GI surgery, most of those cancers, 74 studies, 7,500 patients, and look at that. Overall infections, intra-abdominal abscess, anastomotic leaks, and now mortality. And then look at this paper just published 2 weeks ago, immune modulating forms of patients undergoing cancer chemotherapy, published in it's actually not in press, it's now published. Annals of Surgery 2019, just a couple of weeks ago, decrease infection, decrease of hospital stay. Again, showing us the benefit of fish oils in these populations. So what's the optimal makeup in these patients? I think, weeks, if you have weeks during their workup, when they're getting their CTs and everything else, high protein with exercise. Okay. Immediate perioperative, consider metabolic modulation, arginine, fish oils, maybe carbohydrate hypo-4. We won't talk too much about that. And then post-op, high nutrient balance, high protein, fat content with MCT and fish oils if you can. So we see lots of different things. What's not ready for prime time in cancer? Appetite stimulants, anabolic steroids, nutritional supplements of carnitine, melatonin, anti-inflammatory agents, except for omega-3, don't work. We've tried them. Many cases now, monoclonal antibodies don't work in that chemotherapy. They're not really ready. So remember, cancer cachexia is multiple stages. We have to catch them early, otherwise it's hopeless. If you wait till they've lost 50 pounds and are on the deathbed, nutrition will do them no good, except for maybe some comfort so they get moist in their lips and things. Otherwise, you're wasting your time. You got to catch them early if we're going to show nutrition is going to make a difference. This was a great review here, 11 studies, gave very nice systematic review by Vicky Barakos' group during chemotherapy and radiation. They showed subgroup analysis here, beneficial effects driven by high protein in fish oil. I would recommend this is in a very good journal, Annals of Oncology, 2018. Nice study showing that if we get them early, we can make a difference. If we look at what really made a difference in there, it looks like the subgroups of the fish oil and protein seem to be the best things to go after. So what can we say in conclusion? Because we've got to have a couple minutes for questions here. Set our goals early. Palliative versus curative. Cachexia needs to be treated early. Early identification, I can't say enough about. Prehabilitation if they're going to get surgery or chemotherapy. So remember, we need to be aggressive. So, you know, we've talked about these. Cancer cells, highly efficient metabolically. They go after the machinery of the cell. They change the machinery of the cell. We're starting to learn about ketosis, about fooling the cancer, trying to use semi-starvation diets for short terms. Again, cancer management should include lots of things. Before we talk about whole grains, fish oils, target to reduce food intake so we decrease obesity, increasing exercise because we know exercise decreases cancer. Here's a very nice study in 2011. They implanted a tumor in animals and they trained one and didn't train the other, and look at the growth of that tumor. Decreased the growth of the tumor by 70%. You're going, wait a minute, how can that be? Just exercising? Look at this. Brand new paper published in 2016. They just published in 2019 data. Voluntary running in the animal here suppressed tumor growth. You can see in the bottom there, look at those that got exercise versus those that didn't. Look at the tumors in their lung. Very nice data showing we can decrease that. So exercise is key for all these patients, both in the preventing tumor, but also after you've got tumor and you want the chemotherapy to work and you want the nutrition to work. It does multiple things. It's anti-inflammatory, decreases insulin resistance, increases nutrient uptake by the healthy non-tumor bed. Lots of data going on there. Look at this data here on early mobilization. On the left panel there, we see the blue line. Those are people that got the standard of care. The number of people that actually went to their own home after their hospitalization. Okay, about 50% went home. Look what happens when you do aggressive mobilization and exercise with good nutrition, up to 74% went home. That's a huge difference. Going to a skilled nursing facility or an LTAC, long-term care, treatment care, is a bad outcome. We got to think we want people to go home to a normal life, and that's all what cancer is about. We can do that. In fact, if we give them aggressive chemotherapy with their physical therapy with their ratio. So, thy food shall be their remedy. The words of Hippocrates. We can do it. We can make a difference, but it's got to be early, it's got to be aggressive, and it's got to be combined with exercise. So, I'll leave you with this. The words of William Osler: a good physician treats the disease. A great physician treats the patient who has the disease. Thank you very much for your time. I'm happy to take questions.
Great. Thank you, Dr. Martindale, for a very informative presentation. Our first question here. So there have been some studies showing that higher protein intake can increase the risk of developing cancer. So how is this balanced with recommendations for a high protein diet during cancer treatment? What about for cancer survivors?
Yeah, most of the data that shows increased protein is based on a soy-based protein in breast cancer. And it's not so much the protein there, it's some of the things that come along with the plant-based proteins. That data is still kind of controversial, and I would say you're still better off in the cancer patient as well as in the cancer survival to maintain lean body tissue seems much more important than the small, very small risk in a small population of patients that may slightly increase. The data on increase is a little bit gray and it's a very large doses.
Great, thank you. Okay, next question here. Can you elaborate on the intermittent fasting protocol that you talked about? What does this look like for an enterally fed cancer patient?
Yeah, we can do that. The sort of intermittent feeding, you can feed over 4 to 6 hours and then goes fasting for 16. That's sort of intermittent. But usually you can do these with your oncologist. They're starting to become very popular among oncology settings. of doing intermittent fasting with it and going into ketosis and getting a little bit. But remember, most of that data is in gliomas or brain tumors, not in general, GI tumors. We don't have the data, hard data in humans yet. So be a little careful, but I think there's some value there, and I think we need to study it.
Great, thank you. All right, next question. So what is the best practice for home nutrition support for this unique patient population?
I think, a lot of times they don't like to have feeding tubes and things. So if they look like they're going to need long-term, like we've had very good experience with our head and neck cancer patients, if they can swallow, they're having difficulty swallowing, not eating too much, a little bit anorexic, they can just add in through the peg if they have a peg, to go in. I think supplements, good data on supplements. I think that paper by Vicky Baracos' group shows us, in fact, that if you're not eating well during a meal, some of the supplement data is starting to show if we look at some of the higher protein supplements. So I think we're going to have data to show that if you can't eat a meal, we don't want to go to TPN, but we should try to do supplementation. If they don't do supplements, consider a feeding tube if they're just rehabbing and getting better coming out of a long-term hospital stay or big surgery.
Great, thank you. Another question, you mentioned that software for computing the body composition earlier. Could you elaborate a little bit more about that and how that's available?
Sure, that's available on JPEN January, I think it's January 2017. It may be 2016, but you can look at there's a supplement there that talks about all the protein measuring, lean body tissue measuring, and it gives a website there. I don't have I'm actually in a hotel, so I don't have my paperwork here. It's very valuable and it's free. I love it. It's like a sale.
Great. Okay, one more. So are there any situations where you would recommend TPN besides when the GI tract is not working? Are there any benefits of this?
Well, I'm a little cautious in my answer here because, there's growing trends to the use of TPN. This recent data by Renier in France, not Paris, but in France, showing in 2,400 patients compared head-to-head in sepsis, parenteral versus enteral, and they showed equivalent outcome. I mean, every major paper to then, until the last couple of years, has shown enteral being superior to parenteral for multiple reasons, maintenance of the GI tract and everything else. But I have to say, these couple of papers, the Harvey paper out of England, 2,300 patients, equivalent outcome is parenteral and enteral. A lot of those patients are cancer patients in that study. In the Renier study, it was all septic patients. But so I would say TPN in general, when you compare head-to-head in cancer therapy, TPN has not been good. We've tried to minimize the use of TPN. But with the growing data we have, we're much better now. We have the lipids available that have fish oil in them. We have in the United States that's been approved since August 2016, a mixed lipid emulsion, including soy, MCT, olive oil, and fish oil. I think that's part of it. We also give a little more protein than we used to give. So I think our TPN today is not the TPN of the past. And if a patient is chronically getting well undernourished and you've got no other access, I would consider TPN now as a possible. In general, though, we don't do well with TPN and cancer.
Great, thank you. And then, so you mentioned fish oil. So do you have a recommendation in terms of the dose of fish oil that you would use for patients?
Yeah, sure. Great question. I should have mentioned that. Yeah. We talk, people that do routine 2 grams a day should be plenty, but when you get chemotherapy, it might be 4, or when you get cancer, it might be 4 grams a day. It looks like 4 grams a day, we know causes conversion to increase your SPMs. With the 2-gram dose, increase them, but only by about 14%. 4 grams a day, increase them by 35%, the SPMs. So that data is pretty good and brand new data. So I say 2 grams routinely. if you eat fish, 100 grams of fish, which is just very small, 3 ounces of fish, gives you about 1.5 grams of cold water fish. So if you eat 200 grams of fish, which would be nothing, you got enough for a couple of days. So I think it's better absorbed from the fish itself. So if you can eat the fish, great. If you can't, then I would say eat high fish oil foods. If you can't do that, then I'd take a supplement. Now remember that flaxseed oil and canola oil and the 18 carbon sources of omega-3 don't get converted well in humans. We don't do very well with the conversion. We only convert anywhere from 8 to 12%. Unless you're pregnant, then it converts some more. But generally speaking, 8 to 12%, we need to take a lot of flaxseed oil to get enough omega-3. So we really need to take the EPA and DHA as a source if you can.
All right. Well, thank you. I think that's all the time we have. So thanks again, Dr. Martindale, and thank you to our audience. We really appreciate your participation. On behalf of the Nestle Nutrition Institute, we hope that you found this information useful to your practice and enjoy the rest of your day.